Good morning, good afternoon, good evening for people not in Europe, but welcome to C3 and Society of Occupational Medicine's Occupational Health at Work series. My name is Christine Hancock. I founded C3 Collaborating for Health some 12 years ago now, with the real desire to see the prevention of chronic disease higher up the agenda, and beginning and now knowing really well how complex this is as an agenda. So work is a really important place from our point of view. People are there on the whole from 16 to 70. They still have chances to change, but of course our work's been turned upside down over the last couple of years, and people have talked about it much more. The way of work, not just what we do. So I'm delighted this morning, as we consider the issue of obesity at work from one of the most obese countries in the world, to welcome Steve Bevan from the Institute for Employment Studies, who I've worked with across a range of activities. And I've just confessed to him, I hadn't realized he was doing so much work on obesity. So looking forward, Steve, very much to hearing you. I'll pass the chair over to Nick Powell from Society of Occupational Medicine, but please put comments, suggestions in the chat box, and I'm sure Steve will allow time for questions, and we will be recording the event and it'll be available afterwards. Thanks, Steve, over to you.
Well, I'll just quickly say hello to Nick Powell, Chief Executive of Society of Occupational Medicine. Do put your chat questions in, introduce yourself. After Stephen's done his presentation, we can have some time until 10 with a Q&A, so look forward to that. But otherwise, we really value the collaboration we have with C3. SOM is the professional organisation for occupational health professionals. Do look at our website for lots of free resources, and you can see also we're on the lookout for a trustee if you're interested in that, if you're not an occupational health person, and if you are working in occupational health, to apply for a SOM award. But thank you, Stephen. You're a fantastic leader in the sector and work and health. Really looking forward to this important presentation. So over to you.
Thank you very much indeed. It's really nice to be here. So just by way of background, the Institute for Employment Studies was founded in 1969. We're a charity. We do applied research looking at changes and policies in the wider labour market, but also what's happening in workplaces. And I lead our work on the health of the working age population and how that affects social inclusion, productivity, performance at work. And I've done quite a few projects over the years looking at a range of chronic conditions, from rheumatoid arthritis to MS to cancer, and a few others. We've been turning our attention in the last 2 or 3 years to the issue of obesity. And my colleagues Zafar Burek and I have been doing quite a bit of work looking at the extent to which employment outcomes for people living with obesity seem to be falling behind, and people living with obesity seem to be, in some cases, at a structural disadvantage, both in the labour market and at work. And so we've been curious about this. As we know, obesity represents a significant issue in public health. In the UK, 1 in 4 adults and 1 in 5 children aged 10 to 11 are living with obesity. And of course, obesity is a risk factor for a whole range of other health conditions, type 2 diabetes, coronary heart disease, cancer, stroke, and osteoarthritis particularly. And of course, COVID-19 has also shone a light on the issue of obesity, because obviously we found relatively early on in the pandemic that people living with obesity, particularly if they have a BMI over 40, have an elevated risk of severe disease and death, of course, as a result of a COVID-19 infection. Actually, the Society of Occupational Medicine and others in the UK have led the way in helping to shine a light on this issue, particularly in occupational health terms. So I pay tribute to the work that Nick and his colleagues have done in this area. One of the challenges, of course, of that is that a negative byproduct of the exposure to COVID-19 has been, perhaps in some cases, an increase in the stigma associated with obesity. And so I suppose what I'm going to try and do today is to shine a light on the extent of stigma and discrimination in the context of obesity, and to try and talk about not just how it manifests itself, but also what might be done about it. Now, we all know that it's easy to find contemporary commentary from newspaper and TV pundits, among whom the absence of any scientific credibility has never really been a barrier to sharing their views on both the causes and the cures of obesity. And most of this commentary really has focused on issues like willpower and personal fortitude, with an emphasis on eating less and moving more. And so for that group, it seems that overweight and obesity may be one still of the last acceptable forms of discrimination. And I want to challenge that. We know from the UK published, UK government, probably over a decade ago now, Christine, published a thing called the Foresight Report, which was an extremely comprehensive review of the literature on obesity. And I suppose the big takeaway from that was obesity is an incredibly complex issue. It's not right just to say that there is one cause of obesity. There are genetic factors, there are societal factors, there are public health factors, there are issues around obviously diet and so on. The obesogenic environment was a term coined around that time. And so it of course would be naive to think that there are simple answers to a problem that is so complex and pervasive in society. There we go. So I'm going to talk really about stigma and discrimination in the wide labour market and in workplaces. I want to talk about a couple of particular things. The adverse outcomes for women living with obesity, particularly in the labour market, which seems to come out quite a lot from the evidence. And particularly today, I want to talk a bit about what we found out about worksite health promotion and the risk of internalising stigma at work through well-meaning interventions in the workplace to help people manage their weight more effectively. I do want to talk a little tiny bit about returning to work post-pandemic. But my overarching question really is, what can employers, healthcare professionals, policymakers do to improve work outcomes for people living with obesity? As I mentioned, for many people, obesity remains the last acceptable form of stigma at work. I think this represents a real challenge. It's pretty predictable in the UK, at least, that if a medical story about obesity hits any of the popular newspapers, some people will pile in with the same old stereotypical views about the causes and the cures of obesity. And it's underpinned by this notion that obesity in all cases is volitional. It's completely down to the individual, their lifestyle choices and so on. And that's not to say that doesn't play a part, but it's pretty clear from the evidence that we've gathered and the clinicians that we've spoken to that vastly oversimplifies the situation. Now, we know in the UK, for example, about 45% of employers say that they're disinclined to recruit candidates living with obesity, that people living with obesity have got lower starting pay, they're less likely to be successful in being hired in the first place, and they have lower ratings from their co-workers of their performance and reliability. They're frequently regarded as having less willpower and resilience. And what seems to happen is that people assume that because people live with obesity, they must have poor willpower and resilience, and that therefore that bleeds into their ability to do their job. Of course, there's no real evidence that that's the case, but there's sort of guilt by association. And that means that they're less likely to be regarded as able leaders or to have potential for progression and development within their organisation. And perhaps one of the most worrying things we found was that across the literature, we kept coming across evidence in different domains that women living with obesity, and particularly those working in what you might call customer-facing jobs, have worse outcomes. There's this term that was coined a few years ago by some sociologists called the aesthetic labour market, which is essentially that in some sectors of employment, how you look and how you present yourself is actually seen as really important part of the customer service experience. And certainly we've seen examples over the years of certain organisations, which I won't name, setting out quite strict terms of presentability for people in the front line in customer service roles. We've had at least one international airline recently who have mandated that cabin crew should lose weight before they're allowed to serve on planes, and that's not to do with safety, it's to do with aesthetics. We've certainly seen some hotel chains criticised for being overly prescriptive and discriminatory in the way that they set out their presentational criteria for staff who are facing customers. Now, that's not always about weight. It can sometimes be about facial hair, it could be to do with what people wear and so on. But one of the pervasive things we find in the literature is more and more examples of organisations who regard overweight and obesity as being not appropriate for people in customer-facing roles. And of course, that affects women disproportionately more than men. Now, we know that there's plenty of evidence that employment discrimination and derogatory comments are commonplace, again, particularly amongst women in the wider labour market and in employment. There are a few statistics here, which I won't read out to you, all of them, but we certainly found, as I say, that women do have worse experiences in general. 25% of women report experiencing job discrimination because of their weight, 54% stigma from their co-workers or colleagues, and that women are 16 times more likely to report weight-related discrimination than men. And that women were 37% more likely to report discrimination if they were severely overweight. So, I mean, there's a litany of evidence that outcomes, both in the labour market and in the wider recruitment market and in workplaces, are worse for people living with obesity. And this seems to be baked into the system and also very rarely challenged compared with other protected characteristics, which may be covered more comprehensively by equalities legislation. I want to come back onto that point in a moment. So our evidence review showed that there are a few aspects of the employment journey for people living with obesity where there is not an elevated risk of stigma and discrimination. And it's pretty pervasive. There's research suggesting that pretty much the whole journey, there's different aspects of discrimination and stigma during the recruitment and selection process, in terms of developing employee relationships, well-being. So the issue of mental health comorbidity is something that comes up quite a bit in some of the literature, that you have an elevated risk, particularly if you feel you're being subject to discrimination based on your weight, of developing anxiety and depression. Pay, progression and promotion. I want to talk about pay in more detail in a second, but the way that organisations assess people's potential for promotion, the way they give people access to learning and development opportunities, is sometimes based on an assessment of whether or not you're going to get payback from the investment in someone's skills, for example. And if you don't believe that someone living with obesity is a long-term good bet for the organisation, it may be that even subconsciously you may be less likely to offer people opportunities for training and development, for example. People living with obesity are more likely to leave early, and also if they're unemployed, then they can find it more difficult to get work. But also, if you're living with obesity, particularly with one of the other comorbidities, there is an increased likelihood that you'll leave the labour market prematurely compared with the other people in your age cohort. So, as I mentioned, I want to focus on 2 or 3 of these particular issues. I want to start off by looking at the wage penalty. Now, back in 2016, Dame Carol Black led a review for the UK government looking at what measures could be taken to help people who are alcohol dependent and drug dependent, but also living with obesity. It still actually remains unclear why those 3 were put together. I think even Dame Carol was slightly puzzled about it, but they were. And the idea was to look and see to what extent government policy, but also services for people living with those conditions could be improved to make sure that fewer people who were unemployed as a result of those conditions. As part of that analysis, the UK government review identified what it estimated to be a 10% wage gap between people living with obesity and those people of average weight. but it didn't go into any more detail than that. And so we've taken more of a deep dive into the literature, and we found many studies exploring all this. We were interested to know what the factors were contributing to the wage gap, and also what's the direction of causality. Now, we know, of course, from the work of Professor Sir Michael Marmot and his colleagues at the Institute of Health Equity that employment is a social determinant of health. And when we're looking at health inequalities, it's really important to look at the links between poverty and employment, obesity, and so on. So Michael Marmot, I think really one of the really important points that he makes in his work is that we need to consider what he calls the causes of ill health. So what he says is that smoking, poor diet, obesity are the causes of ill health, but the causes of the causes are the social determinants of health, the conditions in which people are born, grow, live, work, and age. And I think that shines a light again on the complexity of this issue. We're not just talking about individuals struggling with their weight, we're talking about an infrastructure, both in terms of education, wider health, communities, and so on, that reinforces some of the problems that people have about living with obesity, and that having a life course impact. Now, at the same time, living with obesity is therefore linked to lower wages, lower household income through the life course because of gaps in education, poorer health, and employment discrimination. And we were trying to shine more of a light on why that wage penalty was happening. So the evidence is that the wage penalty affects women far more than men. In fact, we even found some studies that showed that being overweight had attracted a wage premium for some men. Now, completely the opposite. But the overwhelming evidence is that living with obesity has a significant impact for many women on their wages. And some studies estimate that gap to be 20%. This is compared with women of normal weight or average weight. And an average pay gap of somewhere between 9 and 13%, which is very significant, and one which, as I said, has a life course impact. This is just not about annual earnings. This is about obesity having an effect on your income or income potential right from childhood or early adulthood into your later career. We know, for example, that women living with obesity at 16 have a 34% lower household income at the age of 42 than women of normal weight. We know too from the evidence that women's earnings peak at a BMI of 22 and then decrease as BMI increases. Decrease as BMI increases. And one study found that a 1-point increase in BMI, and I understand all the challenges about using BMI as a measure, but that's the one that is most commonly used, led to a 4% drop in income within 4 years. And that mothers living with obesity earned almost 7% less than mothers of average weight. And one study found that single mothers living with obesity face a wage penalty of almost 8% per child. So this has a cumulative impact. Part of my role is to work with colleagues at the University of Southampton Centre for Musculoskeletal Health and Work, and they've been doing some work on a study called HEAF, which is Health and Employment After 50, which is a longitudinal study looking at people over 50 in the labour market and the health impact on their participation in the labour market. And a recent study published by them found that older women with a BMI over 40 are more likely to have extended periods of sick leave and to leave employment early. And controlling for age and other health factors, stigma and discrimination play an important explanatory role, even if you take out some of the other factors. So the evidence is coming from all sorts of different sources and seems to be pretty overwhelming. And I suppose the question is, if we're observing this in the data and in the literature, why did that wage penalty exist? And what may be the explanatory factors? Well, there seem to be 4 theories about this, which I suspect overlap quite a bit. There's one group of theories that suggest, which we call human capital differences. So the idea is that women living with obesity have, on average, lower educational attainment, partly because of educational inequalities, limited work experience, are subject to occupational segregation into lower paid, lower skilled, and lower status work. And some studies show there's a strong link between obesity, occupational prestige, and both health and employment outcomes for women. The life course barrier theory is that women living with obesity find it harder to shake off the health and education inequalities of childhood and adolescence. And they live they risk living in lower income households because they're likely to marry or cohabit the women of normal weight. The health differences argument is that women living with obesity have more health conditions and comorbidities that affect their ability to find and retain work. And those health conditions lead to reduced functional capacity in some cases, increased sickness absence, and an elevated risk of premature withdrawal from work for health reasons. And the final one is the stigma, or what some people call taste-based discrimination. So pretty much along the lines of the airlines example I gave you earlier, that women living with obesity are subject to systemic discrimination in the jobs market and in some workplaces. That means they're sorted into low-paying jobs for which they may be overqualified, where opportunities for job and pay progression are constrained, and where negative stereotypes and weight-based stigma are common and normalised. Now, my guess is that each of those play a part in some of the workplace discrimination and labour market discrimination and stigma that women living with obesity are facing, and where it's still unclear precisely in what combination they work for which people, but it seems that all of those are at work. And I think the challenge for employers, healthcare professionals and policymakers are trying to unpick this to try and work out how we can improve employment outcomes. What we also did was some sums to look at how that all translates in terms of the wage penalty at national level. If we just aggregated this up and we took data based on average earnings for women, the prevalence of obesity amongst women of working age, what happens if we do the calculations based on 4 scenarios. So a wage penalty of just 2%, where there is some support in the literature, up to 13%. We could have gone up to 20% because there's, again, quite a bit of support for that in some of the literature, but we tried to keep the scenarios relatively plausible. And of course, what happens if you then calculate the reduction in annual earnings per woman and multiply that up by the number of people involved, for our sort of central case of 9%, which mirrors the broadly what Dame Carroll found in her review, that represents an annual reduction in earnings for a woman living with obesity of over £2,000, and aggregate that up across the whole economy, it's over £10 billion. Now that has, of course, individual and household impact, but also it can reduce at the level of the economy, tax revenues, it can reduce consumption of goods, and also can increase welfare payments. So I think in aggregate, this is not just a bad thing morally and ethically. It certainly doesn't make economic sense for us to tolerate a persistent wage penalty for women. Of course, women have lots of other barriers in the labour market beyond this, and this just adds to the complexity of those, and therefore we need to do, if we're going to focus genuinely on diversity and inclusion policies, this needs to be part of the list of things that we need to look at. The other thing that we've looked at in another paper we've now published 3 papers as part of our programme, the work in this area has been looking at workplace health promotion. And those of us who are familiar with this territory, which I suspect is most of the people today, will know that many organisations are quite keen to use things like interventions to support healthy eating, nutrition, diet, exercise, and so on as part of their array of workplace health promotion initiatives. And those are all well-meaning interventions, and they're all based on the notion that you're at work for quite a lot of your time, and if you're given the opportunity to eat more healthily or to take exercise, and if you are keen to make a change to your lifestyle, then you can do that in a more supportive environment with colleagues and friends at work. So I'm not in any way criticising the motives of that, and as I say, these are well-intentioned programmes. I suppose the thing that we found in the literature review we did is that there remains a residual danger that some of these may inadvertently reinforce obesity stigma, and that is a bit of a challenge and a problem that I think we need to be a bit careful about. It can reinforce the belief that overweight and obesity can be resolved through exercise, the sort of move more, eat less approach, and that those are really mainly achievable by greater application on the part of the individual. And I think that's the challenge. I think our view is that UK employers could be a bit more thoughtful about the inclusion of weight loss and healthy eating elements in their workplace programs, at least the way they're pitched. And some of them, I think in our experience at least, have been a little bit evangelical in the way they do this. And there's been several studies that show that many employees living with obesity are reluctant to participate in those programs, particularly those in lower status work and those with pre-existing health conditions. Certainly the work of people like Dr. Stuart Flint and colleagues, there's a reference there at the end, Talbot and Flint, suggests that this can also reinforce the notion that it's your fault as an individual. So in a sense, it can help internalize the stigma that people already feel they have because of their weight, and that actually perversely a well-meaning workplace can have the risk, elevate the risk of people internalizing the stigma that they're facing already. So that is something that we need to be careful about. And certainly I think having programs that encourage competition between people or use incentives can also produce negative outcomes for people living with obesity. The third thing I just want to mention, this is sort of hot off the press, so I've only really got one slide on this, is that we've just published a third document where we were looking at return to work protocols. Now again, I have to pay tribute to Society of Occupational Medicine for the work they've already done on this. I've produced some really good material on return to work from an occupational health perspective aimed at employers in the sort of post-pandemic or post-COVID world, and I think that there's really good work going on about long COVID as well. We published something which draws on quite a lot of that and other material, but with a focus particularly on how employers who have employees who are living with obesity might need to look at return to work through the lens of people living with obesity. So the structure of it is perhaps not very controversial and what you might expect, requesting that employers do good planning, risk assessment, good consultation, have sensitive return to work conversations, return to workplace conversations, because people who've been working at home have been working, how you go about working out, opening up, and then how you review it. This is partly prompted by obviously the concern about the elevated risk of severe outcomes for people living with obesity through COVID, but also because of some reports of some relatively insensitive return to work measures that were being used by some UK employers. There was one I remember who asked everyone to email in their waist measurements to the organisation so that that could form part of their return to work planning. It was sort of done relatively context free and was a bit regarded as a bit insensitive. So one of the concerns we had is that given the challenges that people living with obesity already have in different parts of their sort of HR experiences, we didn't want to add to that. We wanted to help employers to mitigate any potential problems around this. And this toolkit that we've produced has been so far well received. We've even had some requests from internationally to replicate it and to translate it into one or two other languages. So that's very positive. And I think it just forms part of the wider community of work in this area, which is trying to illuminate this issue and to get employers to think a bit more carefully about how they manage this whole issue of stigma and discrimination at work. We've been having some thoughts also about the policy levers that might be pulled in this area, and you may have views about this. And I'm just I'm flying kites here. Really, these are issues which I think are being discussed in some respects, but we haven't really bottomed them out. But I think we need to. So the first one is perhaps an old chestnut in some ways, but there is still a continuing debate about whether in the UK, at least, we should be categorising obesity as a disease in its own right. I think the WHO first classified obesity as a disease in 1936, and the American Medical Association in 2013, and the German Parliament in 2020. I suppose the idea is that designating obesity as a disease makes it easier for the National Health Service to develop a national service framework, clinical guidelines, care pathways, clinical audits, data registries, commissioning protocols, attract resources, and perhaps eliminate the postcode lottery, and certainly in weight management services in the UK, which is by all accounts a little bit chaotic. Now, I'm not a clinician, so I don't really have a clinically informed view about this. I know it's controversial. It's a bit like the debate about whether pain should be considered a disease in its own right. But some people argue that its designation, obesity's designation as a disease, would open the gateway to better resources and better planning. Now, whether that's sufficient reason, I don't know. You may well have views about it. The second area is whether or not, under UK equalities legislation, obesity should be much more explicitly categorised as a protected characteristics, together with other, cancer, gender, and so on. At the moment, obesity is not explicitly covered by that legislation, although if a person has a medical condition that's linked to their obesity, then they may qualify as having a disability in accordance with the definition of the Act set out. If an employer treats an employee differently due to disability related to obesity, or fails to make reasonable adjustments in line with the requirements under the law, excuse me, this may give rise to a claim for discrimination. I suppose our view is that it's still relatively unclear, and if you're an employer, it's still unclear whether or not living with obesity is something that's covered by the Act, and therefore the ambiguity is just not helping. And I think putting it under as a protected characteristic would resolve the ambiguity, and it would strengthen the rights of employees, and over time make discrimination on the grounds of obesity far less common and less acceptable than it is. The other thing that we think may be important is the whole health technology appraisal process, which most countries have a mechanism for, and most of us become more familiar with in some ways during COVID and vaccine development. In the UK, we have a body called NICE, which essentially does that work on behalf of the Department of Health and Social Care. It assesses the cost effectiveness of medical interventions. At the moment, in most cases, it's not allowed to take into account labour market participation under what we call the societal perspective in assessing the cost effectiveness of treatment. So if access to medical intervention improves your ability to stay active in the labour market and prevent you leaving work prematurely, that isn't properly routinely taken into account in the economic evaluations that are done of interventions. Now, in the case of obesity, there are a number of interventions, obviously, and I think compared with some other health conditions like rheumatoid arthritis, it may be less critical. But I haven't really seen a debate about whether or not, for example, bariatric surgery, which is generally regarded as an effective and cost-effective intervention for some people living with obesity, also has benefits in terms of people being able to remain active at work. And I think that's something that we need to be debating. At the moment, we're only allowed to take a very narrow clinical perspective in assessing the cost effectiveness of such interventions. So that's something that policymakers might want to think about. Fourth, I think it's relatively simple and probably shouldn't just apply to obesity, is that the employment status of subjects in all clinical trials should be collected. For many clinical trials, we just don't know what the employment status is of people taking part of those trials. If we're interested in whether or not people living with a whole range of chronic conditions have better work outcomes as a result of an intervention, we need to be collecting the data. I don't say this with any prejudice or with any hidden motive. It just seems to me if we're interested in work as a clinical outcome of care, then we need to be collecting really basic data about employment status. And I think that's absolutely the case in the situation with people living with obesity. We also know that there are various instruments around for people living with various chronic conditions, which measure work instability. It's a way of assessing the extent to which people's functional or cognitive capacity resulting from their health condition makes them more vulnerable to job loss. And it's a way of intervening really early to assess what support someone might need if they're at work but struggling because of their health, to make sure that they are able to stay active at work, even if it means making temporary adjustments for them. Now, there are work instability measures for a narrow range of conditions, but there doesn't seem to be one on obesity. There's only just one published from the Scandinavia on mental health, for example. Most of them are around chronic conditions such as inflammatory arthritis. So I would suggest that some work could be done to look at this so that actually employers and occupational health people have access to toolkits that enable them to make assessments, not just of individuals, but of workplaces that help assess the risk of someone falling out of work because of their health condition. And then finally, I would say that in the UK, not just in Westminster, but across the devolved administrations, although we have a relatively new obesity strategy in the UK, it hardly mentions employment at all. There's one line in it about exploring what more employers could do to help support people with their weight. And I suspect that's going to be along the lines of diet and nutrition when we drill down into it. And it seems to me that actually there are far more things that we could be doing to try and reduce stigma and discrimination. And employers play a part in that, but policymakers and healthcare professionals do. And I don't see enough of a story about how we want to try and improve employment outcomes and social inclusion for people living with obesity through interventions in the labour market and in workplaces. So there are at least 4 actors here who need to do more: the government, employers, healthcare professionals, and the media. You will have noticed that I've been using the term people living with obesity throughout this presentation. That's part of the shift towards what we call people first language. And it's a really important, it may sound linguistically awkward, but actually we're working a lot with people who are living with obesity. We have Sarah LeBrock on our advisory group, on our programme of work. And it's really important to people living with obesity that we get the language right. And one of the areas of UK society, at least, that needs to improve in this area is the media. And what we're trying to do is make sure that we're using language and terminology that's respectful, but also destigmatizing. So that's a really important part of all this. That's the end of what I had to say. Thank you all very much. I would like to just acknowledge the financial support of Novo Nordisk in supporting our programme of work in this area. Part of the arrangement is that they support us, but we retain full editorial control over the work we do. We have upcoming outputs coming over the next few months. One is a guide for healthcare professionals in terms of talking to people living with obesity about their employment. And the second is quite a large survey we're doing of people themselves living with obesity, talking about their employment experiences. And so we'll have some primary data to report, hopefully by March next year. But thank you very much indeed for your attention.
Thanks very much, Stephen. That's really, what a great presentation. You're such a good presenter on a whole range of issues, but excellent. Thank you. I've got some questions from the audience, and I encourage people to put questions in the chat or come off mute and show yourself on the video. But Sheila Chu has said, would you include cultural perceptions and cultural relativity, or relativity of obesity as one of the factors explaining the wage penalty?
Ooh, do you want to say a bit more about that?
Well, maybe Sheila can say. Sheila, do you want to come off mute and just explain your question? Sheila, yeah.
Yeah, no, Sheila is here. Do you hear me?
Yeah. Okay.
The thing is, I didn't hear a lot on the social determinants of health, because sometimes, obesity is defined socially in such a way that when you are average weight, people will tell you are skinny, and therefore you are bound, to then, be one of those who has gained weight. But whereas at the workplace, it's not acceptable. So I'm trying to see where in the, society should also be one of the actors. And at the same time, maybe we need to also look at those cultural perceptions of who defines what is obese. I know health does, but socially people, especially in my environment where people used to lose weight because of HIV, a lot of people tended to then want to have put on weight so that they don't get that stigma of being told, you have lost weight, you must be having HIV. So it's really that.
Yeah, thank you for that. That's really helpful. I think you've hit upon something that's really, really important. And we do recognise, and I'm sure Christine, through her work globally, will recognise this as well, that there are quite different cultural norms around what an acceptable body shape is, and weight and so on. And the example you give, Sheila, is a really good one. The other one that we've come across is, which we haven't looked at in our study, but perhaps we should, is the whole issue of eating disorders as well, and the relationship with mental illness. This is, of course, the more you get into it, the more complex it becomes. And I said it was complex at the start, and my presentation hasn't really dug into the wider range of complexity, but I think it really is important. And I do recognise that in some cultures and in some countries, what is regarded as normal or acceptable varies enormously. So I suppose your question really is a wake-up call to us here in the UK to make sure that we're not blind to some of those issues as it affects people in the UK, at least, from different cultural backgrounds, and have to recognise that we can't just apply one standard, which is partly comes back to what I said earlier about the controversy about the use of body mass index, for example, as a measure, because I know there are lots of people who argue very strongly that there are other measures that are more appropriate and more flexible and less stigmatizing and so on. So your point is well made, and it's something we will definitely keep in mind as we continue the work that we're doing in this area. Thank you for the question.
Thanks. So I'm interested, actually, Sarah Brady's put a comment in. I don't know if you want to come off mute and about your work with Women Raw for Change, and then obviously it'd be great to hear from Christine as well.
Hi, can you hear me?
Yeah.
Yeah. Hi. Yeah, really interesting talk. Thank you so much, Stephen. I really enjoyed it. I come at it. I have a really good understanding of obesity because, first of all, I suffered with obesity for 40 years. I was first, used the term as obese at age 7. And it wasn't till I was in my mid-40s that I self-motivated myself through an 8-stone weight loss. I've maintained that weight loss for 3 years. And I now work full-time with women all over the country to help them lose weight. And I can absolutely assure you that obesity is a disease of the mind. And the key to people losing weight is understanding themselves, being allowed to let go of trauma of being brought up in poverty, and whatever reason that they are reaching out for this food. And absolutely, people do get discriminated in the workplace, particularly, actually, it's not so much gaining employment, it's being able to go any further within it. Now, women hold themselves back as well, because when you're overweight, you feel like maybe you're not going to be able to achieve the things that you want to. They don't believe in themselves so much. But also employers do bypass them. They don't look at them because of how they look physically. Bariatric surgery and things like that. 50% of my clients have already had either gastric sleeves or bypasses, and they are all regaining. It seems to be, Stephen, after about 2.5 years, because they're not fixing what's going on internally, what's going on mentally. What was that initial impulse for them to begin to overeat? And I know personally, I had to deal with all of that before I was ever going to be able to lose my weight in a sustainable, maintainable way. And that is just through, we all know, look, the reality is women who are overweight, let me tell you, they probably know more about food and nutrition and losing weight than the average person on the street, because they have done it so many times. But every time they start to regain, they look at that as a complete failure. So they lose trust in themselves. But it's because they're not dealing with the root cause of why they have begun to overeat. And my business doesn't just deal with what to eat. We deal with the why they personally reach for that food. And I'd like to know why, so much money is being thrown at surgery and no money is being thrown at actually the mental health condition, which I see obesity as. And I wondered how you viewed that, Stephen.
Yeah, really good points. Very interesting, and in a sense, your question also reflects, the complexity and the fact that no two individuals are the same, and a lot, is about their upbringing, obviously there's quite a lot of work. I did a presentation the other day with Dr. Giles Yeo, who's done a lot of work on the genetic underpinnings of obesity for some people as well.
Yeah.
So putting your finger on just one single cause, as you're finding in your work, is very difficult, and you have to work with individuals. Certainly the view that we've got talking to a number of clinicians in this area is that certainly in England and Wales, the weight management services in the UK really need to be looked at again. It's very patchy. I absolutely get what you say about bariatric surgery. As I say, again, I'm not a clinician, but certainly the evidence I've seen is that in most cases where it's successful, it's cost effective in the sense that it has an effect of reducing people's risk of type 2 diabetes and costing the NHS more as it
temporarily.
Yes, that's right. Well, I think we don't know enough, as I said earlier, about the impact it has on people of working age, and I think that's something we need to look at quite urgently. And it absolutely shouldn't be seen as a panacea at all. Although we tend, I think, to do less bariatric surgery in the UK than occurs in other countries, partly because we do have lots of doubts about it.
I live in the southwest, and our hospital gives out more than anyone else in the country.
Right. Okay. Well, it certainly shouldn't be a sort of knee-jerk response and regarded as the cure, because as we know, the results of the cause is so complex. I mean, I think providing support to people to help them understand what it is that may be about their initial upbringing or the choices they're making and so on has a part to play. And certainly most of the clinicians we talk to about this say that has a big part to play. You do really need to think about understanding the mental health underpinnings as well. And that's more complex. It's not just that you have a mental health issue and then you become obese. It could work the other way.
I agree. There's lots of women I'm finding, I believe, are untreated ADHD as well.
Maybe.
There's the more individual women I work with, certainly I'm seeing traits, and then they're going and they're getting diagnosed afterwards. So
yeah. We also know that people living with conditions like schizophrenia have an elevated risk of obesity because of side effects of antipsychotic medication. So again, you need to really to take a sort of proper comprehensive case history of an individual, as you are doing. You're in a sense the embodiment of
I'm changing the world, Stephen. I'm going to change the world.
Okay. I want to bring in Christine. Thanks, Sarah. That's really, really helpful and great to hear your work. Just in terms of what your perception, just in terms of your projects, Christine, and people wanting to understand about chess and what that is, but also just your, from your perspective about this issue.
Yeah, thanks. And really great presentation, Steve, and an area about obesity that's not talked about, not understood enough, which is great. My challenge to you slightly is, so what do we do about obesity? So the stigma is clearly one part, but I also, and Nick gave me the clue to comment on work we're doing in working with people, particularly in disadvantaged areas, to look at their environment. Many of the poorest people in our country, but in many other countries, live in environments where it's incredibly challenging to live healthily. So chess is, it's a tool, it's an app on a mobile phone or a tablet that asks really detailed questionnaires that participants themselves do with some guidance from us to really look at what is in their local shop, what is in their local cafes, restaurants, how easy is it to be physically active? And some of the results are really terrible. I did myself an area last month in North London, where I have to say, if McDonald's was in that high street, it would be healthy compared with the shops, the cafes, the restaurants that were there. I was shocked. It was unbelievably poor. And the only fruit and vegetables were outside a store where buses stopped and chugged out their diesel all over the fruit and vegetables that were in a stall in the front. But mainly, there was no fresh food. There was almost nothing healthy. And that's what chess is about. And I have to say, just the use of the tool stimulated a lot of debate from people in terms of, I go in these shops all the time, I've never looked at how bad they are. So we're meeting with that local council, which is going to be interesting because some of the women we walked with, it's a very black area where we were, and they were all black, I think all, are just out to get the council, saying, you know, all they want is the money from business rates. They're not interested in what the shops are selling. Anyway, so that's chess, but also a bit of a challenge, Steve, given that what we know obesity does to people's physical and mental health. Stigma is important, but so's, well, Sarah's work, so is trying to work with people to get themselves healthier.
No, you're absolutely right. And yeah, I mean, I sort of alluded to the Michael Marmot work, which I think is probably where the key is. I mean, I know he's also done work looking at, you know, coincidentally, for example, you know, the location of fast food outlets in deprived areas, betting shops, and so on. I think it is about the sort of the infrastructure and taking a look at all the social determinants of health, and the fact that certainly our data suggests there is this life course impact. So the earlier you can intervene in terms of both public health and in education, you have at least a bit of a chance of breaking this sort of self-reinforcing cycle of people continuing you know, perpetuating disadvantage and poor health outcomes and wide health inequalities through the life course by intervening early on in people's lives. And I know that, you know, he has done work in places like Coventry and a few other cities where he's tried to get a sort of joined up cross-agency approach to this. It's incredibly complicated. And I think he would argue that this is sometimes not helped by things like you know, cuts to public services and public health budgets and so on, where his data, I think, suggests pretty clearly that, you know, some of the deepest cuts in the public health budgets have happened in the most deprived areas of England and Wales. So there is something that government here can do, but also I just also worry sometimes that we're not listening as much as we ought to people in the public health realm who get all this and understand, you know, that they're the linchpins of sort of multi-agency working, and they're finding it increasingly hard to devote resources to these things because they know this is a long game. This is not something you can sort out overnight. It's a 20 or 30 year project, and we need to do something about it. So it sounds like your intervention is a really useful tool, and certainly encourage you to keep going with that because it does seem to be on the right lines.
Thanks.
Thanks, Stephen, and thanks, Christine. I can see Christopher Morley come off mute and stating on chat, our largest employers locally are the public sector. Can they provide practical leadership on this? That's a good question. Thanks, Christopher. I don't know if you want to say much more about that or discuss with Stephen about your views.
Well, most of our other employers are small and medium enterprises, and wearing a different hat, we did some work based in Kent some time ago, and the response from most small and medium-sized enterprises, what's it got to do with me? I haven't got resources or time to do anything about this. I'll hire the people I need when I need them. So that's going to be very challenging because that's the bulk of the employment base. So I think the lead has to come in a practical sense from the public sector. It starts with the boardroom. Look around boardrooms on Zoom meetings over the past few months, and you know, you can see some opportunities there where we might have some better examples in the boardroom. That, you know, let's work down from there. How we do it, I don't know. Personal view is reinstate lunch breaks. People are now doing, as I'm doing today, back-to-back meetings, sitting in the same chair for 8 hours. And we need to stop that and have 55-minute meetings, a 5-minute break and compulsory 1 hour lunch when you don't have meetings. That's a start.
I think that's a commonly articulated challenge, not just in the case of obesity, but other workforce health issues. I mean, I suppose the go-to option that governments tend to take on this is, for example, to look at procurement rules. They want to try and encourage smaller organisations to do more around this, or diversity, inclusion, and so on. Sometimes they have a requirement that you can't get a government contract unless you can demonstrate you're doing something on this. Something I know that Christine will be familiar with from her earlier work is that some large organisations are offering their own occupational health services to smaller businesses in their locations. I think Christine's done work with a couple of the big food manufacturers in the past.
Yeah.
I think the other thing is imaginative work with supply chains as well. I'm an advisor to a project that John Lewis Partnership is doing, which is called the Better Jobs Initiative. And although the focus is on different aspects of good quality work and employment practices and so on, they've been that includes a program on well-being at work. And they've been working with about 30 of their UK-based suppliers to try and support them to improve their practices across a range of areas, including well-being at work. And they're not saying unless you comply, you can't be a supplier, but they are edging them through support to try and raise up the standard of the work they're doing across these areas. And so far, that's been pretty successful. And the next stage is to extend that work into their supply chains in both India and China. The power of supply chains and procurement can be part of the answer to this. I'm certain it's not the total answer, but I do recognise that most people work in small and medium-sized enterprises, and both government as an employer, but also as the sort of ringmaster of policy, could be a bit more imaginative about supporting larger employers, including themselves, to do more for SME.
That's a good comment from Katie Cooper. Thanks, Katie, about Obesity Health Alliance. So if you want to come off mute, it'd be good to hear about that. But we are pretty much out of time. It's absolutely been a great webinar, Stephen. I don't know if Katie, if you're still there.
I am, yes.
Yeah, just say about that. That's great.
Yes, I just wanted to flag up the Obesity Health Alliance, which is a coalition of around about 40 of the Royal Colleges and NGOs in the UK with a focus on obesity. Have recently produced quite a substantial document on, it's essentially a 10-year healthy weight strategy that will direct not only the internal thinking in the Obesity Health Alliance, but it contains about 40 recommendations for government. And stigma is very much, it's got a chapter of its own, but it's very much a thread that runs throughout. And obviously workplace health is part of that. But I also thought it's very interesting that it's framed as a healthy weight strategy. We're back to the kind of the respectful language and so on, people living with obesity, but it's actually about more than that. It's about being of a healthy weight. And that kind of framing, I think, I'm sure Steve would agree, can be quite helpful within the workplace as well. It's not stigmatizing. It doesn't make people different. I was very struck years ago, Christine will probably remember this, hearing Ted Kyle speak in the States, and he was talking about workplace health. And he said, as an employer, you may go in with the best of intentions and say, I really want to support you to help you lose weight and to make you, to improve your well-being. And you say that, but what people hear is you're fat and you're costing me money. And it's incredibly stigmatizing. So I just wanted to recount that. I think that really made an impression on me, and it's affected all my thinking about workplace health ever since.
Brilliant. Thanks, Katie, and thanks everyone for their contribution. Christopher, Sarah, Christine, obviously Stephen, thank you, brilliant presentation. We have got next month the Medical Council on Alcohol. That's going to be on the 30th of November. That's the next one. Looking forward to that with their medical director. So, tackling some big issues here. Quite good timing before we hit the Christmas season, thinking about alcohol. Sorry, that's a bit flippant, but thank you so much for everyone for attending. Again, Stephen, thank you, Christine, great partnership with her with C3. Let's keep this focus going. I can still see some chat coming in about People First campaign from the European Coalition for People Living with Obesity. Thank you, Cherie. We can keep this open if people want to have a chat, but otherwise, I'm taking the suggestion from Christopher to have a break, cup of tea, and not just go straight from meeting to meeting. So do that. But thank you, Stephen, and Institute of Employment Studies doing great work. And have a good rest of the day.